DY Patil lecture series. We are happy to have with us Dr. Ashutosh Shah as a speaker again today. He's been a faculty on our platform for a while now, and we are happy to have him back with us. Welcome, Dr. Ashutosh. Thank you for taking the time to be with us in a busy schedule. We're also very, very thrilled to have another very dear friend of mine, Dr. Umesh Nagapurkar. He will be chairing the session today and mentoring us. It's my privilege to introduce to you Dr. Umesh Nagapurkar, who's done his post-graduation from BJ Medical College, Pune. He's amongst the senior-most psychiatrists at Nashik right now. He has had an illustrious career so far, professionally as well as in terms of academics. He's been the president of the IPS West Zone from 2022 to 23, and he's also been the Central Council member. He is an excellent clinician, but also a keen academic. I've had the pleasure of being with him at various platforms and various conferences, and we are very grateful to him to have taken the time to be with us today. Thank you, Dr. Nagapurkar, and we are very, very glad to have you on our platform. Hope to have you back again. I hand over the proceedings to you, and I shall come back at the end of the day to give my closing remarks. Over to you, Dr. Nagapurkar.
Thank you, Dr. Rashmin, and it is really, I'm really glad to be part of this academic series that DY Patil University has been doing since last so many years, and I'm thrilled to listen to Dr. Ashutosh, who has been also a great friend and a very good psychiatrist. He has done his MBBS, DPM, DNB, and he has experience of more than 25 years. He has more than 13 publications to his credit. He is currently working as consultant psychiatrist at Sir H.N. Reliance Foundation Hospital, Mumbai, and he has special interest in mood disorders and schizophrenias and dementias. Now, coming to today's topic of catatonia, I still remember my PG days when catatonia was very prevalent, rampant, I would say. And with advent of lorazepam, we used to have only lorazepam and ECTs as a part of treatment for whether it was schizophrenia or mood disorder. But nowadays, even though the prevalence has gone down in OPD practice especially, but we often see cases in our consultation liaison practice and in ICU settings too. And with in last few decades, we have been very much into this brain biology and the mechanisms, various mechanisms, because earlier we used to have only serotonin, dopamine, and norepinephrine as a biology of brain. But now, since the science is progressing, we are getting more and more insights into brain and the psychiatric disorders, especially now catatonia. And I hope that Dr. Ashutosh will be guiding us on this aspect too. Thank you. Over to you, Dr. Ashutosh.
Thank you. Thank you to Dr. Rashmin and Dr. Umesh for having me here, and a warm welcome to all the 19 people that are here. I will start by sharing the screen. Okay. So I can see my screen. Okay. So if the screen is visible, I will start with the topic of catatonia. Now, catatonia. Yeah. Okay, thank you. Catatonia, what I'm going to do is give you all a broad overview. It's a very big topic. So in order to have everybody's attention, I'm going to actually just give a broad overview. And the term itself is coming from the Greek word kata, meaning down, and tonos means the tension. So reduced tension, that is what catatonia is. And even though, as Dr. Umesh said, that the incidence or the overall incidence of catatonia in our OPDs are going down, the fact is, globally, the prevalence of catatonia has actually increased, and this is an absolute increase, not an artificial increase. Anyway, moving ahead, a little bit of history of this catatonia. So most of you may be aware that it was Carl Ludwig Kalbaum who had coined the term catatonia. But even much before Kalbaum, catatonia was being described. However, the previous people were not able to integrate this into a syndrome. So there have been descriptions of catatonia right from early 1800s. That means almost more than 200 years. It was Kalbaum in the year 1874 where he published a monograph, and this was actually a monograph of 26 cases. And he believed that this was an independent entity, an independent syndrome, a kind of a affective and motor syndrome. So that means a psychomotor syndrome. And he had given this publication. Subsequent to Kalbaum's publication and recognition of the whole disorder, what had happened was, in the beginning of the 20th century, Kraepelin and Bleuler, basically these two, subsumed this particular thing under schizophrenia as a subtype of schizophrenia. So what happened was, we saw that Kalbaum said this is a psychomotor syndrome. Subsequently, the shift happened that this became a motor syndrome. And now, in the year 2022, with the ICD-11, it has again classified catatonia as a psychomotor syndrome and an independent diagnosis. So it's no more a subcategory of schizophrenia, because in fact, a lot of so-called psychiatric causes of catatonia, the patients have actually a mood disorder rather than schizophrenia as the underlying cause. So this is the brief history of catatonia, that it was already recognized more than 200 years back. 150 years back, the term was coined by Kalbaum. He gave a in-depth description of this syndrome in 26 of his patients. Subsequently, in the beginning of 20th century, Bleuler and Kraepelin made it into a motor syndrome and a subcategory of schizophrenia. And now, very rightly in 2022, ICD-11 has again re-established catatonia as an independent diagnosis and a psychomotor symptom. So what is unique about catatonia? This is one syndrome where you don't need a subjective history. You just need to see the patient and you can diagnose. There are very few such diagnoses in psychiatry. Catatonia is one of them. And essentially, the patients can present either with a lot of movements, that's hyperkinetic, or a reduced movement, that's hypokinetic, or abnormal movements, that is parakinetic movements. And of course, what I'm going to focus over here is acute catatonia, but you also have chronic catatonia, the periodic catatonia, which I'm not going to focus much in this presentation. And the causes of catatonia may be n number of mental illnesses, n number of secondary medical conditions, and n number of physiological or psychoactive substances. Overall, the prevalence in psychiatric units is anywhere between 5 to 18%. In fact, within psychiatry, almost 25% of the patients may be having catatonia, but it may not be recognized. And in the neurology in patients, this prevalence is around 3.5%. Now, as I said, there is evidence to show that the incidence of catatonia is actually increasing, and this is an absolute increase. However, the recognition is not happening. And one of the main reasons is there's a lot of heterogeneity of presentation. That means no two patients of catatonia may be same. And this may be one reason why catatonia is underdiagnosed. In fact, I don't know how many of you as residents have actually so far had a case of catatonia in your particular experience. But the whole thing is catatonia is often missed out. And it also has a high mortality rate. So there is actually a risk to the life of the patient if it is not recognized. So early recognition is crucial, and that may lead to a favorable outcome. Now, as I said, the motor symptoms, when we say psychomotor, we are essentially looking at motor phenomena, affective signs, as well as the cognitive behavioral disturbances. Now, you can have different kinds of motor phenomena. If it is hypokinetic, it may be stupor or posturing, And if there is hyperkinetic, then you may have stereotypies, and if it is parakinetic, you may get vexy flexibility, etc. And affective signs, often the patients experience intense anxiety or intense fear, but it's not apparent. They appear to be having a flat affect, but internally they are feeling a lot of anxiety and fear. And sometimes they may have impulsivity. And in terms of the behavioral disturbance, there may be mutism, autism, which is the same as social withdrawal, negativism, then the echo phenomena, and grimacing, mannerisms, automatic obedience, and rituals. I would not be going into definitions of each of this. They can be found in any standard textbook. So the abnormal psychomotor activity, here the motor and muscle tone are affected either in posturing, flexibility, or catalepsy, or there may be mannerisms, stereotypy, and grimacing, and the echo phenomena, as well as mid-gain mid-matching, which is an exaggerated response to the slight touch also, and Gegengreifen. That means the patient keeps on having an inviting gesture despite instructions to the contrary, and there may be verbigeration or perseveration and other signs of abnormal psychomotor activity. And for decreased psychomotor activity, we are looking at essentially stupor, akinesia, mutism, negativism, staring, ambitendency, flat affect, and affective latency. And for increase, it may be agitation, impulsiveness, combating, and automatic obedience. The fourth symptom, which is not often recognized, is actually autonomic abnormality. So, this particular category, if you see DSM-5-TR, it is not having this, but ICD does have this, as well as certain rating scales like the North of Catatonia rating scale. So here there is an inclusion of temperature, blood pressure, pulse, respiratory rate, and sweating or diaphoresis. Now, autonomic abnormalities may be pronounced what's known as a malignant catatonia, which carries almost 50% lethality. So that means these are actually life-threatening. So coming to diagnostic criteria, though there are several signs which I have already listed before, what happens with DSM-5-TR, it gives only 12 as a recognized diagnostic criteria. And you need just 3 out of 12 to diagnose catatonia as per DSM. Whereas if you look at ICD-11, in total there are 16 criteria, and again you need 3 out of these. Now, some signs are found in almost all patients, be it mutism, stupor, or posturing. So, most of the patients of catatonia will have staring, stupor, mutism, or posturing. And very less patients have some signs, maybe less than 1 in 5. But when present, they are almost pathognomonic of catatonia. These are the echo phenomena, that means echolalia and echopraxia, maxi flexibility, and catalepsy. So catatonia may emerge rapidly with a peak within few hours. So that's an acute catatonia, or it may develop slowly over a period of days or weeks. That's a chronic or a periodic catatonia. Now, this may persist. That means the catatonia, which is occurring periodically, may persist for years. And this is often seen in patients with schizophrenia spectrum disorder or those with neurodevelopmental disorders like autism. The course of catatonia due to an intoxication or other medical condition would depend on the underlying condition. So, for example, catatonia is often found in patients with anti-NMDA receptor encephalitis. So, almost up to a third of the patients, or even two-thirds of the patient, may have catatonia, and it will persist till the underlying cause is not going to be corrected. And there are almost 9 clinician administered scales for catatonia. They have been validated. But the two most frequently used are the Bush-Francis catatonia rating scale, which consists of 23 items, which has an inter-rater reliability of 0.92. And it also has a screening subcategory scale, which has 14 items, which again has a good inter-rater reliability of 0.95. However, for this Bush-Francis catatonia rating scale, this inter-rater reliability is only achieved when the clinicians are trained. So the address seen on your slide is the address which you can go to, the internet address, to train yourself on the Bush-Francis catatonia rating scale. The other most commonly used is the North of Catatonia rating scale. So essentially the difference between these two, So Bush Francis is actually more focused on the motor symptoms. There is practically no inclusion of the affective domain, whereas the North of Catatonia rating scale, which has 40 items, actually is including even the affective symptoms. So it truly covers all the domains, the motor symptoms, the affective symptoms, as well as the behavioral symptoms. Now, what I've done in this slide is I've given signs which are found with high frequency, and I've given a color coding. Green means this particular symptom is included in ICD-11, and blue color means this symptom is included in DSM-5-TR. And when you see both, that means the symptom or the sign is present in both this diagnostic classification. And at the same time, I've given a brief description of the particular sign. So what is found in high frequency, that means very frequently in most patients of catatonia, is staring, stupor, mutism, and posturing, of which staring is included in ICD-11 but not in DSM-5-TR. The moderate frequency are the ambitendency, the negativism, the stereotypy, rigidity, agitation, grimacing, and mannerisms. So these particular symptoms are not as frequent as the previous ones, but they are found in moderate. That means in some patients, and of these, rigidity is only included in ICD-11, but not in DSM-5. And signs with a low frequency, the echo phenomena, verbigeration, waxy flexibility, and catalepsy, these are found in very few patients, but when present, they are almost pathognomonic of catatonia, of which verbigeration is found only in ICD-11. So coming to the lorazepam challenge test. Now, before I actually go and explain this particular slide, a little bit of background. So I heard Dr. Umesh say that previously the treatment was only ECT and lorazepam. It still is only ECT and lorazepam largely. But before this particular availability of lorazepam, so actually the use of lorazepam in catatonia occurred for the first time in the year 1983, though lorazepam was introduced somewhere around 1977 and it was discovered in the mid 60s. So in 1983, it was Dr. Edwin Cassim who, for the very first time, used lorazepam for 4 cases of catatonia and found a dramatic improvement. And thereafter, it is history. It has been used frequently, in fact, almost as a diagnostic particular test. And what was happening before lorazepam? If you all have any clue, just make a wild guess. I'll give you a few seconds if anybody has it in the head. Okay. So before lorazepam, it was actually ECT which was used, as well as amital. That means this was the substance which was used for treating catatonia from the 1930s. And before 1930s, they were using ECT as well as the camphor-induced seizures to treat catatonia. Now, the introduction of lorazepam, which acts through the GABA A receptor, it's a allosteric modulator, was definitely a big game changer. So what happens is, before administering the lorazepam, either orally or intramuscularly or intravenously, the difference is only the time it takes to peak level and the bioavailability. One can do the Bush-Francis catatonia rating scale and note down the total score. And one can give intravenously 1 to 2 milligrams of lorazepam, which can be repeated for a second time. Usually, after giving it anywhere between 5 minutes to half an hour, the symptoms subside by almost 50%. So you can re-administer your Bush-Francis catatonia rating scale. And if there is a reduction by almost approximately 50%, it's a positive lorazepam challenge test. Even if they do not subside, you can still repeat again after, say, maybe 5 minutes to 30 minutes and see if there is a reduction. If positive, it is very likely this patient definitely has a catatonia. So in practice, whenever the person is having a substantially altered level of psychomotor activity, and if you are having a high suspicion of catatonia, you can give lorazepam. If there is symptom remission more than 50%, definitely this is catatonia, and you diagnose it as per ICD-11 or DSM-5-TR, and you continue your therapy with lorazepam. And if there is a lack of response in cases with a high index of suspicion, you give a second dose. And if there is a symptom remission by more than 50%, you diagnose catatonia and continue treatment. So some patients may require even as high as 16 to 30 milligrams of lorazepam a day, and they do not get sedated. So it is being used. There are case reports of even high dose of lorazepam up to 30 milligrams a day. Now, as per the Western world, roughly 66 to 100% of patients will show a response. That means there is roughly around 40% of patients who may not respond to lorazepam. And those with a high index of suspicion of catatonia, if they do not respond to lorazepam, then you give electroconvulsive therapy or ECT. Now, here there is a little bit surprising data which has been coming, is that for studies from Asia and India, anywhere between 0 to 100% of patients are showing a response to lorazepam. That means Asian patients and Indian patients are having a lesser kind of a positive lorazepam challenge test or a response to lorazepam. The reasons nobody knows. In cases where the suspicion of catatonia, that's on the left side of your screen, in cases with low suspicion of catatonia, the same thing, you assess the symptoms with any scale, give the IV lorazepam. If there is a remission more than 50%, this is catatonia and continue with lorazepam. But if there's a lack of response and a low suspicion of catatonia, then definitely please consider alternate diagnosis. So what are these alternate or differential diagnosis? I've listed them on this slide. This is not comprehensive. I'm not going to be reading the slide. The slide sets will be provided. It will be available on the website. But to give you some examples, say for example, delirium. Now, delirium, especially in the elderly, may coexist with catatonia. So it's not a mutually exclusive diagnosis. But in delirium, when you give lorazepam, there may be actually worsening rather than an improvement. So up to 30% of patients of catatonia may have coexisting comorbid delirium, which means the remaining 70%, it may be a differential diagnosis. And I'll show you all in the next slide what may be the differences between these two particular disorders. The other differential diagnosis on the slide, I'll just pick one, say maybe locked-in syndrome. Over here, actually, the MRI, that's an investigation, will show a pontine lesion, and clinically, the person will have preserved vertical gaze and blinking. So they are actually eager to communicate, unlike catatonia, where there is a lack of communication. And there is definitely no response to benzodiazepine. So you may see on this particular slide a lot of different neurological conditions, different psychiatric conditions, which may mimic catatonia but is not actually catatonia. So the differential diagnosis may need that you call in specialist like a neurologist to examine the patient and help you derive a firm diagnosis. So coming to this slide, again, I'm not going to read each and every line over here, but the salient thing, what differentiates catatonia from delirium, the first thing is there is a fluctuation of their alertness and arousal, which is in delirium, unlike in catatonia, where there is actually no waxing and waning of the alertness and arousal. The patient may be awake, conscious, and depending on whether there's a hyperkinetic or a hypokinetic state, you may get either staring, mutism, or there may be increased movements. And if it is coexisting with delirium, there may be also a fluctuation. So arousal is one thing which may help you differentiate. The other thing is the thought process. In delirium, it is often disorganized. You may get hallucinations or sometimes delusions. In catatonia, usually you get a repetitive and stereotype thoughts. Perseveration is common, but there is an absence of thought process abnormality. But it's very hard to figure this out in a patient who is not communicating with you. The third thing would be orientation. If at all you can check the orientation in the patient of catatonia, they are often maybe clear, but it is very difficult to kind of figure it out. But in delirium, definitely they are disoriented in time, place, or person. And this may also help you differentiate. So these are the three things. And the fourth one, obviously, is the response to benzodiazepines. Usually, delirium worsens with benzodiazepine unless and until it is secondary to withdrawal of benzodiazepine or due to alcohol withdrawal, whereas catatonia improves So both all these four particular things may help you distinguish between that may be a overlap. That means up to 30% may have comorbid catatonia and delirium, especially in the elderly patients. And for management, there will be a difference for these cases, which I'll speak when we come to the slide on management. Now, speaking of pathophysiology of catatonia, now before I actually go into this subject, what is important to understand is because catatonia has had different perspectives, be it Talbot's legacy, where it was viewed as a psychomotor disorder, or the Kraepelin and Bloyler's legacy, where it was viewed as a purely motor disorder, and the neuropsychiatric perspective from the Wernicke-Leonard school, the research also has mimicked or mirrored these particular schools of thought. So you will definitely find research papers which are only focused on the motor aspects because they have believed it as a motor disorder. So accordingly, the differences of the findings in different papers would come up. Now, neuroimaging studies, essentially fMRIs, here they have used motor behavioral rating scales. As I said, the Bush-Francis catatonia rating scale, which is predominantly focused on the motor abnormalities. These studies have suggested changes in the dopamine-mediated cortical and subcortical motor regions. And research using the North of Catatonia rating scale, which includes the affective and the behavioral sim, they have found higher order abnormalities in the frontoparietal networks, which are insufficiently modulated by glutamate and GABA. So depending on what was the school of thought, they have given different findings. And studies with periodic catatonia that has shown left premotor cortex hyperperfusion. Now, the pathophysiology, we can broadly divide it into two, and that may be irrespective of what is causing catatonia, whether a medical condition or a psychiatric disorder. We can look at it from the biochemical or a molecular perspective, and the second is the systemic or a network-based perspective. Now, speaking of the biochemical level or the molecular level, we can see that catatonia may have differences in the GABA A activity. So a increase or a resolution of the symptoms with lorazepam or zolpidem, which are allosteric modulators of GABA A, that may help improve the catatonia, whereas a rapid withdrawal of clozapine or benzodiazepine may lead to withdrawal catatonia. So one receptor which is involved is the GABA A receptor. The second one is the GABA B receptor, where clozapine, GABA B, which has GABA B agonist activity, may help improve the catatonia, especially in catatonia associated with schizophrenia spectrum disorders. But an overdose with baclofen may lead to an increased GABA B receptor activity and may actually induce catatonia. So the overactivity of the GABA B receptor may actually induce catatonia. Looking at glutamate, again, hyper and hyperactivity of this particular receptor. We know that clinically amantadine and memantine are improving or releasing the symptoms of catatonia. So any NMDA antagonist is going to help the condition. Whereas in NMDA receptor encephalitis, there is a glutamatergic hypofunction and there is catatonic symptoms. And finally, dopamine. So here both excess and a less amount of dopamine has been found to be associated with catatonia. So both the dopamine blocking drugs like the typical antipsychotics or tetrabenazine, as well as the stimulants like methamphetamine, might lead to catatonia. So the risk factors for catatonia, the underlying medical condition, which is essentially a inflammatory, systemic inflammatory illness with an involvement of the CNS or a neuroinflammatory condition. Any inflammatory brain disorder, be it encephalitis, lupus, autoimmune disorders like Sjogren's, or antibody-mediated encephalitis, typically the NMDA receptor encephalitis, as well as the infectious causes of encephalitis, be it the herpes simplex virus, the HIV, even COVID-19, or syphilis, or Lyme disease. All these have been reported. This is not a comprehensive list, but all these are the underlying secondary medical conditions which may lead to catatonia. And over here, there's an injury or activation of the innate immune system against the infected cells. Now, if somebody wants to know the detailed, precise mechanism, I'm not going to be speaking of it. about it over here, you can ask me in the Q&A, because I don't want to confuse everybody, so I'm keeping things simple over here. But essentially, it's the dysfunction of the corticostriato-thalamocortical loop. So this is the system or CSTC loop, which is involved in translating motivation into movement. And this definitely is involved. So a motivation and movement is not happening, and that leads to catatonia. The second risk factor is pharmacological. As I already mentioned before, anything which alters the GABA B receptor activity or the dopamine receptor activity, be it due to antipsychotic or methamphetamine, here again there will be a risk for catatonia. So dopamine antagonism may secondarily influence the glutamatergic pathways. So we know that the glutamatergic system, the GABA system, the serotonergic system, as well as the different other pathways are involved in catatonia. And finally, the genetic risk factors. And there is evidence to show that a loss of function allele of a myelin-specific gene is also involved in having a predisposition for catatonia by virtue of either low-grade inflammation or neurodegeneration. And there are also other studies which have shown that a genetic mutation of the GABA B receptor also may predispose to catatonia. So data is emerging on this particular aspects. Now, speaking of the molecular and immunological pathways, there may be a dysfunction of the GABAergic, glutamatergic, dopaminergic, and the serotonergic systems. I'm not talking of the levels of the neurotransmitter, I'm talking of the systems. And autoimmune catatonia may result from the glutamatergic hypofunction. And if we shift to the network perspective or the systems perspective, over here there is altered functional connectivity between the orbitofrontal cortex and the motor or the premotor cortex, with a reduced GABA A receptor density in the left sensory motor cortex. So GABA A receptors are predominantly present in this particular regions, and they are involved together with this particular pathways connecting the orbitofrontal cortex to the premotor cortex. And also there are studies to show that certain cortical features, be it the thickness of the cortex or the surface area or the gyrifications, these also vary across the motor and non-motor regions, and that may be differently associated with catatonia. So in schizophrenia spectrum disorders, those with an ultra high risk for catatonia, these studies have shown they have a thinner cortex as compared to people who did not develop catatonia, though they were having a schizophrenia spectrum disorder. Again, in systems or the network perspective, fMRI studies have shown that in catatonia, which is associated with schizophrenia spectrum disorder, there's a large-scale functional brain network disconnectivity. So in fact, everywhere in the brain, overall, there's a network disconnectivity. And also there's an abnormal brain white matter microstructure. And this microstructural alterations of this white matter is usually in the psychomotor related regions, be it the orbitofrontal cortex, be it the primary motor cortex, the prefrontal cortex, the supplementary motor area, and the basal ganglia. And this may lead to or contribute to the development of catatonia. And there is also data to say that there are key roles for alterations in the volumes of the subcortical limbic structure. And this may account for the affective dysregulation that one sees in catatonia. Again, from the network perspective, there is reduced gray matter volume in the frontothalamic network, and this may reduce the intrinsic neural activity in the frontoparietal cortex. Also, predominantly the frontotemporal pathway is also, or the frontotemporal network is also disturbed. And this results in impaired processing of negative emotional stimuli and cessation of the sensory motor functioning, leading to affective and behavioral catatonic signs. So for network perspective, essentially the involvement of the orbitofrontal cortex, and this helps explain the loss of impulse control, the affect dysregulation, and inability to make decisions. And this aberrant orbitofrontal cortex, prefrontal cortex, and the orbitofrontal and the parietal cortical connectivity. As we can see, these are cortical connections, or what we can say are horizontal connections. They also will be having a disturbance, as well as the cortical and the subcortical network connectivity. So over here, the connections between the orbitofrontal cortex with the limbic system, the raphe which is part of from where the serotonergic system starts, as well as for the substantia nigra, from where the dopaminergic system starts. All these are going haywire, and such alterations may be responsible for the underlying impulsive behaviors, aggression, disturbed affect, and mood regulation. And that explains why patients are experiencing fear. And all these are the characteristic symptoms of catatonia. Now, other studies have shown that subcortical and cortical motor systems, they have found both an increase and a decrease structural and functional changes. So this is a mixed kind of a finding, but essentially this was in the motor cortex or the supplementary motor cortex and in the subcortical regions like the basal ganglia and cerebellum. And abnormalities in these motor regions can still result in aberrant activity of the primary non-motor regions, which are involved in other functions such as the orbitofrontal cortex, prefrontal cortex, raphe nucleus, and the default network region. And all this is then accounting for the psychomotor abnormality and not just the motor symptoms. So essentially, we are looking at three brain structures. We are looking at the prefrontal cortex, we are looking at the limbic system, and we are looking at certain areas within the brainstem and the cerebellum. Now, there has been a systematic review. This essentially covered something like 26 or 33 studies. And what this systematic review has found is there are alterations in the frontoparietal and limbic region, the thalamus and the striatum. And there are different cortical and subcortical brain changes in catatonia, including diffuse atrophy and signal hyperintensities in the frontal lobe and cerebellum. And there may be hypoactivation of the orbitofrontal cortex or both hyper and hypoactivation of the medial prefrontal cortex and increased connectivity of the primary motor cortex and a supplementary motor area, again both hyper and hypoactivation, and increased connectivity of the cerebellum with the prefrontal cortex. And all this is then accounting for the symptoms of catatonia. And there are changes in the perfusion and metabolism in the motor cortex, prefrontal cortex, and the basal ganglia regions. So having seen this particular pathophysiology, coming to management, here broadly the management is of three perspectives. Direct management of the catatonia syndrome itself, which I'm going to elaborate in the next slide. Treatment of the underlying condition, be it a medical condition or a psychiatric illness or both. And this means it's better, prudent to involve specialists from other domains and to have this patient in an intensive care unit, because all this, if suppose it's a NMDA receptor encephalitis, this will need a input from different specialities and an intensive care unit to manage such patients. And the third management principle is to prevent medical complications, especially be it deep vein thrombosis, pulmonary embolism, wet sores, or sepsis, pneumonia. All such complications we need to avoid. And that is the third aspect of the management. So coming to the direct management of catatonia, there are roughly, or there are precisely 6 different guidelines which have been published. So 6 different societies have given guidelines. This is a broad algorithm which has been shown on the slide, that whenever the person is having an altered level of psychomotor activity, and once catatonia is diagnosed, either using a lorazepam challenge test, and if there is no doubt that this is not catatonia, of course, catatonia you can see also on history, the different symptom domains, and diagnostic tests to rule out other medical conditions, be it blood tests, urine drug screening, lumbar puncture, EEG, MRI. Once the diagnosis is firmly arrived, start the treatment. Usually it's lorazepam, and patients would show a response within 24 to 72 hours. And within 5 days, there will be almost complete recovery of the patient. And as I already said before, you may need higher doses of lorazepam. And there are case reports that people have tolerated up to 16 to 30 milligrams of lorazepam. Now, lorazepam is not the only benzodiazepine which can be used. In fact, it's a bit strange that why only lorazepam has been used. You can use any benzodiazepine. You may use diazepam or even oxazepam. But if you search the literature, there are very few studies which have compared lorazepam with other benzodiazepine. There was just one study comparing lorazepam with oxazepam. So over here, oxazepam was used up to 60 milligram, and the study showed that there was equal efficacy of both lorazepam and oxazepam. So there is a need to compare lorazepam with other benzodiazepines also. And simultaneously, you treat the underlying medical or psychiatric disorder. Now, there are certain special conditions. So if it is a benzodiazepine withdrawal catatonia, then you restart the benzodiazepine. Or if it's a clozapine withdrawal catatonia, you restart the clozapine. The precise mechanisms are not known, but it is hypothesized that, say, in clozapine withdrawal catatonia, GABA B receptors may be involved, or even the dopamine receptors may be involved, but nobody knows the precise mechanism. And if it is an antipsychotic induced catatonia, then you stop the offending antipsychotic. And in chronic catatonia, over here, aripiprazole and clozapine are recommended. And in malignant catatonia, you may need high doses of lorazepam or ECT. Now, catatonia which co-occurs with delirium, as I said before, over here, if you give lorazepam or any benzodiazepine, there's a worsening of the patient. So what do? Here you use NMDA receptor antagonists like amantadine or memantine. That has been found to be useful. Memantine between 5 to 10 milligrams and amantadine around 100 to 300 milligrams in a day. So different GABAergic medications are used, as well as different NMDA antagonists are used, and also dopamine antagonists like clozapine. Now, if the patients do not respond to lorazepam, then ECT is the next line. And in facilities where you can give ECT, there is a very high percentage chance of the patient responding, almost to the tune of 90 to 100%. Usually, by the first few ECTs, within 5 to 6 ECTs, the patients would respond. And in cases who did not respond either to lorazepam and ECT, there have been case reports that they have responded to zolpidem. Or you may try out other things like amantadine or memantine in such particular cases. So having seen overall about catatonia, it is important to know that we still need more research in catatonia, because knowing more about catatonia not only would help us to figure out treatment for this particular disorder, but in general give us a deeper understanding of the way the brain works and have a wide impact in the field of psychiatry. And these are the three references which I have used to derive this slide and today's talk. And I would highly recommend the third one, which is actually an entire volume of schizophrenia research, which was released in January 2024, roughly close to 300 pages, but worth every single page. And do take your time to read this particular references. So with this, I will stop sharing my screen, and we will have, if at all, there are any questions.
Thank you, Dr. Ashutosh, for such an elaborative and detailed discussion about catatonia, including historical aspects from Carl Baum and the recent advances in management. I think I still remember, as you said, only a few conditions in psychiatry which have spot diagnosis and don't require any symptoms. Patient can tell you anything about his symptoms. So I still remember in my PG days, the psychological pillow used to have, and because of which we could diagnose catatonia easily. And as you said, the you still get inpatient population of around 5 to 18% of patient catatonia, and it is basically underdiagnosed because of the heterogeneity of presentation. And we need to be really careful because of this mortality rate which is there with catatonia. The symptoms, as you rightly said, motor, affective, and cognitive symptoms, we need to have for diagnosis using rating scales. Major symptoms are stupor, mutism, and posturing, which we need to be diagnosing catatonia. And the lorazepam challenge test basically proves diagnosis of catatonia. And we need to differentiate it from delirium. You also discussed very well the pathophysiology in details regarding catatonia, biochemical and physiological causes, the various pathways. And management of catatonia. It is still lorazepam, and if not responded, ECTs and underlying condition, whether it is psychiatric or medical condition. But we need to diagnose it and treat it to prevent the mortality which is there with catatonia. Thank you very much once again. There is a question here. What is the basis of preferring aripiprazole over other second and third generation antipsychotics?
Okay. So aripiprazole is, as you all know, a dopamine system stabilizer. So apart from that, it also works on the dopamine 3 receptors and also has 5-HT2A antagonism, which essentially means the serotonergic system is not going to get disturbed. So therefore, aripiprazole is preferred. And for the same reason is clozapine. Plus, clozapine also has actions on the GABA-B receptor. So clozapine and aripiprazole are the two preferred agents. And there are case reports of catatonia secondary to risperidone, secondary to quetiapine, but none secondary to so far aripiprazole or clozapine.
Is
One question.
neuroleptic malignant syndrome is also type of catatonia, lethal catatonia?
Yes. So I'm glad you asked this question, Dr. Umesh. So actually, for lethal catatonia, there's a significant the malignant catatonia. There's a significant overlap between the signs and symptoms of malignant catatonia with even neuroleptic malignant syndrome. The difference is actually arbitrary. So what has been proposed is uh, the malignant catatonia can have n number of reasons, whereas neuroleptic malignant syndrome it is just linked to an antipsychotic. That is possibly the only difference between these two conditions. So per se, it represents the extreme spectrum of catatonia, where there's a high mortality, almost 50%. And the treatment is actually same, be it malignant catatonia or be it neuroleptic malignant syndrome. High dose of benzodiazepines or dantrolene or even ECT. So actually, there is not much of a difference between the two conditions. And just to elaborate and take it a step forward, what is presently what can be improved in catatonia actually is there has been a lot of homogenization of the diagnostic criteria between DSM-5, TR, and ICD-11, but still there are differences. And what defines catatonia is still not very clearly specified. You just need to have 3 out of 12 or 3 out of 16. So randomly any, but what is the core criteria that's not still defined? Unlike the North of Catatonia rating scale, which requires one symptom from each of the domains, motor domain, behavioral domain, and affective domain. So this still needs a bit of more consistency. And additionally, the rating scales, be the North of Catatonia rating scale or the Bush Francis, they can actually be converted to a diagnostic system rather than having just a rating scale. The second actual, I would say, not controversy, but need for refinement is the definition. The definition's a bit woolly or hazy. What is the difference between maxi flexibility and catalepsy? It's not very clear. And also, when do you diagnose a particular sign? Is there any time duration? Certain scales have given a time duration, certain have not. So even if you just see once the patient posturing for say 3 minutes, is that posturing, or you need the patient to be posturing for longer duration? So such kind of finesse is still required.
Definitely. Thank you. Thank you very much. And I don't think there are any more questions. Thank you once again, Dr. Ashutosh, for enlightening
Okay,
us in this wonderful topic of catatonia. Over to you, Dr. Ashwin. Thank you.
thank you.
Thank you. Thank you very much. As expected, Ashutosh, you were brilliant. And I think his USP is how he manages to make any complex topic seem quite simple and lucid. So, thank you very much. And it was delightful to see a modern take on a topic which we have grappled with ever since our postgraduate days. And surprisingly, we do still see a few cases of catatonia, not perhaps as many as we did earlier. Fortunately for me, I work in an indoor unit, so we'll end up having a lot of these cases referred to us for management. And like you said, lorazepam is still the go-to. I don't think we use ECTs as much for catatonia directly now, uh, though it's not unsafe to use in any way. But practically speaking, we have seen very good results with all the other treatment options that you have so brilliantly enumerated. So we use it very rarely, but it is primarily for the underlying condition which we are trying to treat as opposed to just treating catatonia directly. But nonetheless, excellent. And thank you very much, Ashutosh, for being with us and helping us understand this complex topic in a very lucid manner. We are very grateful to you for having taken the time. And thank you so much, Dr. Agapurkar, for having taken time out of your busy schedule as well. And of course, all the enthusiastic participants who were with us today. Uh, I would urge the speakers and the chairpersons to not be fooled by the number of participants that you might see attending it, because we have many more number of participants actually revisiting the website later on and seeing the lectures as a download, because all our lectures are available in the slide form as well as the video form in perpetuity. So it might be a little misleading to assume that that is the only audience. This is only a fraction of the total audience. So you are a lot more popular than you think you are. That's the reason why we keep requesting you back time and again. Of course, our gracious hosts support, Sun Pharma, we thank you for your unflinching support. And we hope to have you all back on our platform, the speakers, the chairpersons, as well as the audience, for all the exciting lectures we have lined up for you. We already have almost the entire year schedule already logged in. And you can visit the website to see what to expect in the many months coming forward. And we hope to be able to bring such interesting topics to you time and again. So thank you all once again and have a great evening ahead. Thank you.